cases, fair employment, social protection, and universal healthcare. Universal healthcare is important, but, and I should emphasize this point, when we talk about health inequities, we do not mean inequities in access to health care. Inequities in access to health care are very important, but that's not the start and the finish of health inequities. Health inequities arise because of the conditions in which people are born, grow, live, work, and age. The healthcare system is a response to those decrements in health that arise therefrom. And then in the key drivers, we talk about health equity in all policies, good global governance, gender equity, political empowerment, market responsibility, and fair financing. I'm an epidemiologist by background, medically trained, and I think until the Commission started, I'd never published a paper that didn't have a chi-squared or a regression coefficient or a p-value in it. There was only one kind of research, and that was good quantitative research. But when we were doing our work about health inequities globally, it was clear that if that was the only type of research that we were going to consider, we would have a very short report, which could be summarized as saying more research is needed. More research is needed, but we felt that more action was needed, and we needed to draw on the best research we could of a variety of sorts. Qualitative as well as quantitative epidemiological research, analytical epidemiological research, economic analysis, yes, randomized controlled trials in the few cases where they exist, observational studies, case studies, policy analyses. And I'm not going to go through each of these in turn, but you'll see examples as I go through the evidence of each of these types. It was important to look at research across sectors: economic, social, political, biological, medical, and psychosocial, and research at different levels of societal organization, all of which are important. Simple conclusion is the evidence is not as good as we would like, but we do know enough to take action. Those actions need to be evaluated. So the action and the research need to go on at the same time. One of the challenges for the Commission is that we were concerned with the whole world. How do you make a set of recommendations that apply to sub-Saharan Africa and urban and rural India and Latin America and Asia and New York and Washington and Glasgow and London? An important issue, therefore, we tried to make a virtue of necessity and said a clear set of next steps from the Commission is translating the Commission's recommendations into different country contexts. Brazil took it up. They've had their own Brazilian Commission on Social Determinants of Health. President Lula is holding the report of the Brazilian Commission. I've just heard that there will be a South American Commission on Social Determinants of Health, that 12 South American countries have got together and they're going to have a commission. So very much a follow-on from the Global Commission. India has some other things on their minds at the moment with an election. The result will be due in a few days, I think. Manmohan Singh received a copy of the report, and his question to us was, what do you want me to do? And I thought, I should tell the Prime Minister of a country of 1 billion people what he should do. So I said what I've just said to you, which was, India has made dramatic progress in terms of improvement in health, absolutely dramatic. Improvement in life expectancy of 12.5 years in only 30 years. life expectancy for women now in India is 63, but it's 86 in Japan. Why stop at 63? Why shouldn't it be the same in India as it is in Japan? We don't think there's any good biological reason why that should be the case. I venture to suggest, I said to the Prime Minister, that were countries to take up the recommendations of the Commission, they could make a big difference. But how this should play out in an Indian context, or rather in Indian contexts, plural, has to be worked out locally and nationally. So were you minded to take the Commission's report and set up a process to translate it into specific recommendations, it might make a big difference. This is the President of Sri Lanka. They also have something else on their minds at the moment. But they do appear minded to try and review the Commission's findings, I think once they've got this other minor difficulty off their chests, of how they could take action. In Britain, the Prime Minister, we had a conference in November to launch the report. In fact, one of my colleagues said, as the Prime Minister's popularity plummets, I should take his photograph off this slide. But still, he did announce that he's asked me to conduct a review of the Commission's report and what it means in Britain for further action to reduce health inequalities. The line we took, we used the simple phrase, the causes of the causes. In public health, people talking about causes often talk about smoking, about high cholesterol, about dirty water. These are causes of disease. Our concern was, what are the causes of smoking? What are the causes of bad diet? What are the causes of dirty water? Not just knowing that attention to those. And the focus is on social inequities and health inequalities. We have 4 goals for our review of health inequalities in England. The first, and we've set up a committee to look at it, is to look at evidence relevant to future policies and actions. And building on the work of the Global Commission, we set up 9 task groups, and they reported to us in April this year. We've only got 12 months to do it. The second is to recommend quantitative objectives for reduction of health inequalities and means to measure progress. The third is to show how that evidence can be turned into practice, and then, importantly, part of our terms of reference is to publish a report. We've had the experience of reviews of health inequalities that didn't get published, so that's part of the terms of reference. And we set up 9 task groups that are somewhat similar to the Commission's knowledge networks: early child development and education, employment, social protection, built environment, sustainable development, social exclusion and social mobility, priority public health conditions, and delivery systems. This logo here, we put some thought into the logo. If you imagine that this is life expectancy over time for 3 groups, high status, middle, and low, it represents the social gradient, the fact that health inequalities are not confined to bad health for people at the bottom and good health for everybody else, but it's socially graded. And over time, what we'd like to see is everybody's life expectancy going up, or their health improving, but a narrowing of the gap. So the logo, in a way, sums up what our credo is. We very much think that planning action on social determinants of health and health equity has to be put in the context of sustainable development. We have to bring the agendas together of thinking about a green future and an equitable future. So to give you some examples of some of the evidence that we've been developing for our domestic review, but drawing on the work of the Global Commission. Our knowledge network for the Commission on early child development put great emphasis not only on child survival, not only on physical development, but on cognitive and linguistic development of children and on social and emotional development, both for the health of the children and for their health when they become adults. These are data from the 1970 birth cohort in Britain. This measure here are relative positions on a measure of cognitive development at 22 months of age. So you can see here children who had low cognitive development relatively at 22 months of age, and divided into those who were brought up in families of low socioeconomic status and those brought up in families of high socioeconomic status. As they're followed over time to 118 months, you can see that those of low socioeconomic status who were relatively low remain low. Those who are low, but in families of high socioeconomic status, actually catch up. There's some regression to the mean here. And you look at those who are high to begin with, those in families of high socioeconomic status retain their high cognitive development relatively, but those in families of low socioeconomic status get a decline in their relative position on the scale. Now, if you make the assumption, just for a moment, that cognitive function at 22 months was biologically determined by genes, by birth trauma, what happened in the first year of life in terms of early nutrition, then even making that assumption, that baggage, that biological baggage you bring with you to age 22 months can still be very powerfully affected by the social circumstances in which the child then spends the next few years of life. Now, in fact, cognitive development at 22 months is not all purely biologically determined. There's big social environmental effects. But you can see that those effects can be powerfully impacted by what happens subsequently. Employment arrangements and work conditions. Unemployment rates by level of education in the UK, 1997 and 2006, they went down, but those with low education had higher unemployment rates than those with high, and it was a graded phenomenon. There's a rumor that the economic downturn is going to affect bankers and those in the financial sector. Like all such rumors, it should be disbelieved. In absolute numbers, firstly in the rich countries, it's going to be those of low skills, low education, who are going to be much more affected than those of high incomes, quite apart from less social protection when they lose their jobs. And when we look globally, it's going to be people with low incomes, people in vulnerable and insecure employment, who are going to be much more affected than those in rich countries. And it's important to health. When we had the last big rise in unemployment in Britain in the early 80s, we saw these powerful impacts. First, look at people who were employed in 1981, and this is social class. Class 1 are the professionals, 5 is the unskilled manual, and you see the social gradient in mortality. It's not just the bottom versus the top, but it's a graded phenomenon. Now look at those who are unemployed in 1981 and subsequent mortality. Each social class has higher mortality when unemployed than the equivalent social class who remain in employment. So we reproduce the social gradient, but all at a higher level. Particularly with the economic crisis, conditions at work might get tougher as well. We've been very interested in the nature of working conditions, not just job insecurity and unemployment, but what happens at work. And one way of looking at stress at work is the so-called ISSC concept. It's people who are socially isolated at work and in high-strain jobs, high demands, and low control. In our Whitehall 2 study of British civil servants, we've looked at this ISSC, demand, control, support, and calculated the population attributable risk. In other words, what proportion of coronary heart disease incidence is attributable in this working age population to being in jobs characterized by high demand, low control, and low support. And the answer is about 25%. Another way of looking at stress at work is effort-reward imbalance. We've also looked at organizational justice at work. And combining these, the population attributable risk is about 30%, and adjusting for all other predictors, it's 29%. So that's adjusting for smoking and cholesterol. So stress at work, as we've measured it, demand, control, support, effort-reward imbalance, lack of organizational justice, accounts for about 29% of the heart attacks in this working age population. Social protection. Professor Jerry Morris in England, who celebrated his 99th birthday last week, after he turned 90, published a paper on minimum income for healthy living for people who are dependent on the state pension, people 65 and above. And he said, what does it cost to have a healthy life with respect to diet, physical activity, body and mind, psychosocial relations, getting about, transport, medical care, hygiene, and housing? And he calculated that, I think it was 2007, for a single person aged 65 and above, they would need about £125 a week. The state pension was about £85 a week. So for a single adult over 65 dependent on the state pension, we pay them about 2/3 of what they need to have a healthy life. We've made a societal decision that we won't give older people enough to live on. There's no shortage of money. There's lots of money. It's just how we choose to use it. Built environment. Children in the 10% most deprived wards in England are more than 3 times as likely to be hit by a car than children in the 10% least deprived wards. So traffic's an issue, but it affects people depending on where they are in the social gradient. Those who are more deprived appear to be more vulnerable than those who are less. People with low socioeconomic status are less likely to exercise than those with high socioeconomic status. People in deprived wards are exposed to poorer air quality. And people who live with high levels of motor traffic are more likely to be socially disconnected. One calculation done by a group that's given us evidence for our domestic review, looking at the impact of 20-mile-an-hour traffic zones. And they've calculated here the number of actual and predicted casualties. So this is the predicted casualties if there were no 20-mile-an-hour zones, and these were the actual casualties, and these are casualties saved by level of deprivation. So it's not huge, but you can see that actually implementing speed restrictions would be a step in the direction of promoting health equity. And it's a graded phenomenon. Our task group on urban development says that no one should live more than a few minutes from green space. And they pointed to the evidence linking green space to mental health, to children's play, to social links, and to obesity because of opportunities for exercise. Sustainable development. As I said at the beginning, we need to bring these two agendas together. Certainly, our Sustainable Development Task Group said GDP is not growing. That's got to be a good thing. Why do we want GDP to grow in a country like Britain? Globally, it might be a different issue. If you're in India and the GDP grows, you've got some more money to do things. But in a country like Britain, growth in GDP, the way we currently organize things, is only bad for the environment and the planet. We need to bring these agendas together. When we look at the heat wave in Europe in 2003, the excess deaths, we all know about France, 14,000 excess deaths, but there were a number of excess deaths in other countries. And who died in the heat wave? The elderly, those with loss of autonomy, socially isolated, living directly below the roof of a building and living in cities, a heat island effect. And I would say just as unemployment, just as the economic crisis, so it is with environmental effects, so it is with tsunamis. It's the poor and disadvantaged who are much more affected by these external events than the rich and more advantaged, and it's a social gradient. Hence, one of our recommendations is health equity in all policies. We didn't want to do this whole review and forget public health, priority public health conditions, forgetting smoking, forgetting eating and obesity and so on. And we didn't want to forget mental illness. This is the prevalence of mental health or ill health by household income in England, 1998 and 2003. And quintiles of household income. If anything, the social gradient has got clearer over time. The lower the household income, the higher the prevalence of mental illness. When the Acheson Committee in Britain produced its report 11 years ago, and the evidence, I was a member of that committee, the evidence that we got on mental illness, we asked what could we do to reduce inequalities in mental illness, and the experts talked only about treatment, detection and treatment, nothing about promotion or prevention. I hope that my review will have something to say about prevention of mental illness. Prevalence of obesity among adults by income quintile, 1998-2006. For a long time, we'd seen the social gradient in obesity in women, but less so in men. But it's become clearer that there's a social gradient in women and in men, and the prevalence of obesity has gone up at all levels of income. So we've got this very clear social gradient by income quintile, but it's risen dramatically between 1998 and 2006 in only 8 years. A huge issue stored up for the future. Economic analysis. I've already shown you Jerry Morris's calculation on social protection. There's a rumor that the world is flat. These are incomes, poorer countries, richer countries, and poorer groups and richer groups within countries. Yeah, I guess that flat is a reasonable description of all of that, which actually covers most of the world. So most of the world is flat in terms of income. We've just got these skyscrapers up here, dramatic. As Nancy Birdsall said, the idea that the world is flat is not an accurate description. The world is marked by deep craters and huge peaks. And the ability and the capacity and the opportunity of people to benefit from globalization depends whether they're down in a crevasse or already up in a peak. The benefits of globalization are most unequally distributed, and this particular graph comes from our Globalization Knowledge Network. My colleague over there from the news group, Nordic Experience of the Welfare State, the Swedish government supported a Nordic group. We asked our Nordic colleagues, what can we learn from the Nordic experience of the welfare state that might be applicable more generally? And they produced these data for us, among a number of other things. These are poverty levels, where poverty is defined as less than 60% median income, before and after welfare state distribution. So in the US, poverty levels here at about just over 30% are lower than in the UK. The effect of the tax and benefit system is to reduce poverty levels in the US by 24% and in the UK by 50%. In Finland, Norway, and Sweden, the effect of tax and benefits is to reduce poverty levels by more than 70%. So we said that the Minister of Finance is involved in ethical decision-making that potentially has a profound impact on health inequities. It's a key example of how actions in other sectors potentially have important impacts on health equity. And the poverty, of course, is not some external characteristic or it's not in the genes, it's actually a policy decision, how the money within a society is distributed. And in the session that I was in before lunch, how money is distributed between societies. And if we look at what's been happening amongst OECD countries, this is real earnings growth for men and women working full-time between 1980 and 2003. So in the UK, men and women, by decile, all deciles got an improvement in earnings, but the magnitude of the improvement depended on where you started. Those who were higher income to begin with had a bigger increase. So income inequality went up, but everybody got better in real terms. This is the United States. For men, everyone below the median, the bottom 5 deciles, had a decline in earnings growth. So the US, like the UK, had an increase in income inequality. The difference was things got worse for the bottom 50% for men. So this dramatic increase in income inequality and worse economic conditions for the bottom half of the population. It's not a total surprise why the US might have worse life expectancy than the UK, given this history. Let me come back to where I started about our inadequate evidence and quote Goethe, who said, "It's not enough to know, you must also use the knowledge. It's not enough to wish, you must also act. Thinking in order to act, acting in order to think. That's the sum of all wisdom." I think we need to put together the taking of action, the evaluation of what we do, and the continuing development of knowledge, because this is what the Commission was trying to do. Thank you.
Thank you very much, Michael, for a really fascinating overview of your work. We have a few minutes for questions that are directly related to the presentation, and then after we will have at the end of the session the opportunity for a debate and a panel. Are there any questions at this stage? If not, then let's move on. And Ashok, can I ask you to come to the rostrum? So the next speaker is Ashok Yasudian, and who is the Dean of the School of Health System Studies at the Tata Institute for Social Sciences in Mumbai. And Ashok has been active in health policy and system management for the last 30 years, focusing on urban health, health policy systems, and so on. And he was also at WHO as a manager of the Alliance for Health Policy and Systems Research. So Ashok.
Thank you. In my presentation, I just focus on the Indian context related to social determinants of health. And I didn't know Sir Mohammed had met the Indian Prime Minister and he has shown interest, but we will know only next week who will be the Prime Minister. So if he is going to continue, surely this is a very interesting area to take forward. The Commission's report has huge interest in the Indian context because of the factors that exist in the country, because it's a country with a multicultural and multi-ethnic, multilingual society with a pluralistic health system. It has a health system, huge government network, private providers who are not regulated, and it has allopathic system, Ayurvedic system, Siddha, and so many other systems. So it's a very complex health system as well as a very complex society. And the inequality in health status and inequity in accessing health resources is a huge issue in the country, and it's impacting on the overall health status of the society. Socioeconomic determinants like poverty, social exclusion, and gender, these are, very strong social forces that has to be addressed. Access to basic health services, this is a issue because the country is predominantly rural, only less than 30% urban, and it is not only rural, then the tribal areas are far-flung. So how do we access, how do you ensure a health service for the people who are in the far-flung areas? It's a major issue. The other one is the health workforce shortage, this overall shortage of 400,000, they say, it's estimated, of health workers, and doctors' shortage is acute. It is not because there are less number of doctors, but also an issue of how they are distributed all over the country. So I will be just looking at evidence in these three areas. One is on inequality and inequity in health services, gender and health, and medical workforce shortage. So I have just quickly, I will look at evidence in these three important social forces. So this is the first one. This is the study, I think, yeah, it's more clear here. I have taken these 4 states. This is the southern state, Tamil Nadu, Karnataka, Maharashtra, and Gujarat. And these are the 4 states which are economically most advanced in the country. And the health status of these 4 states are above the national average. So I was looking at infant mortality in these 4 states in a longitudinal fashion, and also looking at the institutional delivery as a key factor, health system factor, impacting on infant mortality. So looking, so I have taken the National Family Health Survey data, that is what normally called the Demographic Health Survey, DHS data of the country, and analyzed that this is the Tamil Nadu in the beginning, which has from 92 to today it is the 30. But if you look at the state of Maharashtra, where I come from, Mumbai, it has started at a very low infant mortality, but its progress is very dismal from 92 to 2005. If you look at 2006, it's very slow. And if you look at the Gujarat, which is today the upcoming economically very fast-growing state, it is started, these three states have started at the same level in 92, but you can see Tamil Nadu has gone to 30, but these two states, Karnataka, where the Bangalore, the technology city is situated, where this is moderate, but here it is very dismal, though the state is very progressive economically. And this is the national average. So, and then I looked at the next, I was taking in account the wealth quintiles. So if you look at, it is not only those states are doing badly generally, but also if you look at the inequality in health status, if you take Tamil Nadu, here the richest have 23.2 and the poorest 53. But if you look at the Maharashtra, the richest 27, but it's 95. If you see Gujarat, the richest, the infant mortality is 32, but the poorest, it's 100. So it's not only these two states are doing badly generally in the infant mortality, but also this inequality in health status is very wide. And if you look at the health system in the states, Gujarat is a very typical example of talking about public-private partnership. In the sense, the institutional delivery, they have a very fascinating program called Chiranjeevi Yojana, which means that private gynecologists are enlisted and the government bears the expenses of the people who are below poverty level. So that's kind of a scheme. But more, whereas the Tamil Nadu, which is doing well and where disparity is not much, which is entirely a government-run health system. It has a 3-tier primary health care system and 24 hours, 24/7 obstetric care, and where you find much better results as compared to a system where most of the services are outsourced to the private sector. Now, the institutional delivery, again, if you look at it, these states, Tamil Nadu is doing extremely well, which has predominantly a public health system. That's what I was telling. Whereas the Gujarat, you could see it's the institutional delivery is quite low, and national level is still very dismal. And again, if you go back, again, I take the income quintiles. You see here the poorest 68 in Tamil Nadu, the richest 98. It's not much. Inequity is not much. But look at the Gujarat, where the poorest access to institutional delivery is just 15%, whereas the richest have 85%. Similarly, this state, Maharashtra, 21 and 94. The richest have 94, poorest have 21. So you could see the Tamil Nadu, which has established a very good network of public health system, which has achieved this equity to a great extent, whereas in spite of having this public-private partnership and other thing, you can see the access to the institutional delivery is extremely poor. This is reflected on the infant mortality in the state. That's the thing. So now I'll move on to the next one, gender and health. Here I'm looking at the spousal violence and impact on the health status of women. So this is the national data you have. And spousal violence against women and their spousal violence means the 3 types of violence: sexual violence, physical violence, and emotional violence. So these 3 have been taken together here. So you can see this is the never experienced violence, where the body mass index less than 18.5 is 29, whereas it is those who experience violence, it is 37. Similarly, the anemic, the difference you could see, and the ever terminated pregnancy, again, it is 15% who did not face violence, 21% who have faced violence, and current pregnancy unwanted is also high on those who experienced spousal violence. Then second one, the sexual violence alone. The evidence show that, especially here, the genital sore and ulcer is much higher those who have experienced this sexual violence. And genital discharge, again, is much higher for those who have experienced this sexual violence. Also, next one, I will move on to the access to health services and spousal violence. You can see variation. The antenatal care, at least one antenatal checkup, you could see that it is less here. And those who have antenatal care for everybody, all recommended ANCs, generally it is low in the country. It is, the numbers are not visible. I think it's some 8% and less than that. And here it is the assisted by, again, health professionals, which includes institutional delivery as well as at home assisted by a professional health personnel. 57% in the case of those who did not face violence, but it is something like 30%. And institutional delivery, again, you see the difference is 50% for those who did not face violence, whereas it's 30% for those who faced violence. So the spousal violence and its impact is quite revealing in this. The third one is a study on the medical workforce shortage. This is a study conducted in the state of Maharashtra. And Maharashtra is a state which produces the largest number of doctors in the country. 17% of the doctors come out of the medical schools in the state. But there is acute shortage of doctors in the government services, that 25% of the primary health centers do not have doctors, and 40% of the rural hospitals face shortage of doctors. Whereas the number of doctors in the state there's very large number. So I looked at the final year students and looking at their career aspirations, what they plan when they come out of these medical schools. So the profile of the final year medical students basically shows that they are predominantly male, 2/3 are male, and they are very young, not married, and 2/3 almost come from million-plus cities, metropolitan cities, and 82% belong to the upper and middle caste, which basically reflects that they come from upper and middle class society, and 30% are really very rich, and 31% come from doctor's family. So already they have their parents are doctors, our father is doctor, our mother is a doctor. Now I looked at the profile of those who are not opting for government job. So those who are not opting for government job, when you look at it here, you can see it is predominantly male who would not like to join the government, and also the younger lot compared to the higher age group. And so this is the kind of a demographic profile. If you look at their social profile, the religion may not show much, but here you can see those who are not opting. This others is basically the upper caste. This is the government terminology. The other backward caste, which is basically the middle caste. So you find this is the group which is not opting for the government job, whereas you find these scheduled castes and scheduled tribes. These are again the government terminology for those. These are the tribal groups, and these are the groups which are really government wanted to uplift them. So these are the lower caste system. This percentage is much lower. And see here, the bigger city, metropolitan city, they are not interested in this. As we go to the rural and tribal area, those who are not opting, the percentage is shrinking. Then this is quite a clear thing that as income increases, the not opting for government job also increases. So this is so these are the three studies which I was analyzing to look at how these social factors impact on two of them on the health problems and one on the health system. So looking at that, I have borrowed this from the Commission's recommendations. So these two, basically what I have just discussed about, the improved daily living conditions, including circumstances like spousal violence, and people work, grow, and tackle inequitable distribution of access to health services and resources. But my concern is, social science concern is here. Measure, understand the problem, and assess the impact of action. So this is the area I think in India we need to look at it and look for much better scientific studies, social science studies we need. And that is the area needs. So I just looked in the next two slides, look into the social science research. So the way forward, I have first one is on building social science capacity. So they need to create a critical mass of social scientists to work in the field of health, which is currently we have large number of social scientists. Like I come from a social science institution, we have 150 social scientists working there, and the School of Health system is the smallest school there, where we are maybe about 15 of us working, and in the School of Social Science, maybe a few others working. But in the university departments, in other large universities, you don't find hardly any social scientists are interested. And the silver line is the India is today in the last 5 years, this first time the public health institutions, training institutions are coming up. Because previously we have always the public health is part of the medical school, where preventive and social medicine is the department which was doing a kind of public health. But here now we are establishing School of Public Health and also MPH program coming up. So it's at this stage it's very important to ensure that social science become a very strong component in these schools or institutions involved in public health research and training. Then the next one is a closer link between the Indian Council of Social Science and Indian Council of Medical Research. Social science, actually in 1978 at the declaration, Alma-Ata Declaration, afterwards the Indian government set up a commission which consisting of ICSSR and ICMR. And they came out with a very classic document of analysis, Health for All. That was the basis for the 1983, the first national health policy. And at that time, they have a joint commission which was working, so that has really, over a period of time, that has disappeared. Then the commitment of government to finance health services, especially in the light of National Rural Health Mission, where $250 million annual outlay, where there is hardly any research to give direction to that program. The last thing is to interface between research and policy. This is another area which needs to be emphasized, that need to communicate research findings that can help the policymakers. There is hardly this interaction that is taking place. And also a lot of social science research remains in the universities and in the libraries. And for that, I think creating a platform for social scientists and policymakers to work together and create so that the research agendas are set in such a way they are used for policy making, which I was suggesting a model like the Indian Health Observatory in line with the European Observatory, which because the reason is that we have 29 states having 29 health systems, and which may be much heterogeneous than the Europe, and also culturally the country is maybe much more heterogeneous than Europe. So I just thought that Indian Health Observatory may be a way forward. Thank you very much.
Thank you very much, Ashok, for expanding actually on Michael's talk and emphasizing a few issues that are extremely important, like gender also, I think, and diversity. Any questions directly related to this presentation, and again, we'll have opportunity for debate later on. Well, thank you very much. And then we have our last formal presentation by Jenny Popey, who's the Professor of Sociology and Public Health at the Institute for Health Research at Lancaster University. And Jenny brings with her not only the British experience, but also some solid African experience, and even from New Zealand, I understand. So, Jenny.
Thank you very much indeed. And now, as they say, for something completely different. I don't think there's any numbers in here apart from the number of knowledge networks associated with the Commission on the Social Determinants of Health. What I want to do is three things. I'm very briefly going to give an overview of some of the research priorities that were identified by the 9 knowledge networks associated with the WHO Commission. I'm then going to spend most of my time focusing in detail on one of those priority areas. That's this area called research on lay knowledge, which I don't think in the last day and a half we've spoken about very much as social scientists. And then finally, I want to make some relatively brief comments about the knowledge networks as a form of building capacity for research in health equity or for health equity. So the 9 knowledge networks, Michael went through the list of knowledge networks that are linked to the English review that he's now involved in, that I'm supporting as well. They're broadly the same: early child development, employment conditions, gender, globalization, health systems, priority health conditions, urban systems, and social exclusion. And then there was a cross-cutting knowledge network looking at issues of measurement. And the reports of the knowledge networks, together with the final report of the Commission, are still on the WHO website. So they're worth looking at. All of these knowledge networks collated very diverse evidences, and they all made recommendations about future research, as well as collating research that could lead to immediate recommendations for action. So obviously with 10 very extensive reports, I can't do justice to all the recommendations for research, many of which are relevant to the social sciences. So I just have categorized them and illustrated some of the key types of research. So the first area was around what we refer to in the knowledge networks as a gap in the problem space, which is understanding really the relationship between these macro social determinants that Michael and Ashok have been talking about, and the individual experience of ill health, and as well as the gradient across societies. So, for example, there is not a lot of research linking major processes of globalization to the individual health experience. And that kind of mapping of the socionome to match the mapping of the genome is really vital to taking forward the research, the evidence base for future action. The second area of research priorities was gaps in what we refer to as the solution space. Really, what should we do about these things? As Michael said, there is a lot of evidence already there for action, but what all of the knowledge networks found is that a lot of the research is in high-income countries. It's in the West, and a disproportionate amount of the research comes from North America. So there is a really urgent gap. It's not that there isn't action and innovation going on in low and middle income countries. We found a lot of such action and innovation, but there is a shortage of evaluation of that action. So we need more evaluation of action, and in particular we need more research-based evidence from action in low and middle income countries. But then there are also some methodological gaps, some really important methodological gaps. And perhaps the best example of that is this current crisis, financial crisis really, that the methodology for evaluating interventions cannot be applied to evaluating what we might call a natural experiment, though maybe an unintended experiment in the sense of the financial meltdown. But we need better social science designs for evaluating these national experiments, whether they're experiments in terms of, for example, a new supermarket in a local area, a new road going through a neighborhood, or major global initiatives like the neoliberal reforms in Latin America, for example. So there is a methodological challenge for us in terms of evaluating action for health equity. A number of the knowledge networks, and particularly the gender knowledge network, focused on the problems with the way we analyse, the data we collect and the way we analyse our data. And too often, globally, data on sex and age are either collected and not analysed or not collected. So they're key dimensions of equity. There currently is a problem with the evidence base not being able to be analysed in a way that will allow us to even map the inequities, let alone begin to act on them. And of course, again globally, in all our countries, there are key groups of people who are missing from the research. From a global level, the most obvious groups would be the millions of stateless people, and people living in informal settlements. But even in England, where we have this vast history of social epidemiology and research on health inequalities, we still know that there are key groups missing from our evidence base because we do not have the methods for recruiting them and retaining them in research. And then, of course, there is a major challenge for us about utilising the evidence we already have. The Cochrane collaboration is doing a courageous job in the medical area, and increasingly the Campbell collaboration is similarly collating evidence on social policies. But we need methods for collating much more diverse evidences. Both of those collaborations focus on only experimental designs. And of course, many of the wider social determinants will never be evaluated using experimental designs. So we need both to systematically and transparently review more of the evidence, but also develop methods for doing that in a more inclusive way. And then finally, across all of the knowledge networks, there was a concern around the democratization of research. And there were two key issues there. One was the need for science, and this applies as much to social science as to any other domain of science, to involve the public in the research process, right through the research process. And to do that not simply because we want to get our numbers up, which is a preoccupation of all scientists in England at the moment, but to do it so that we produce research that is more relevant, more appropriate, more credible. So public involvement in social science, in science, is a crucial challenge for all of us, I think. And then the second issue around the democratization of research, I suppose, is this issue of lay knowledge, of people's knowledge, and how that is missing from the evidence base at the moment. And that's a particular challenge for social science, really. And I want to concentrate a little bit, I want to concentrate the middle section of my talk on this issue of lay knowledge. So what is it? Maybe with a social science audience, I don't need to say what it is, but actually having sat through a couple of plenaries, then I maybe I do need to say what lay knowledge is. For those of you who don't remember your year one undergraduate social science, all social life is constructed in stories. If you sat in a restaurant last night, you probably told one another stories about what went on yesterday. But these stories are really important. It's not just a leisure activity. We give our lives meaning by telling stories. We all do that. And those meanings that we attach to our experiences give us insight into human agency. The meanings are not the same as mechanisms, which we debated in this morning's session. And meanings and an understanding of meanings are core to what some aspects of social science have been about. So sociologists and anthropologists in particular call these stories or narratives lay knowledge, and we access these stories, we access these narratives using qualitative research designs. But there's a problem. This morning, John Elster talked about history, and And he also mentioned E.P. Thompson's amazing book, the History of the British Working Classes. And E.P. Thompson argues in that book that it's really important for historians, but also for social scientists, to what he referred to as rescue the wisdom of experience from the crushing condescension of history. And what that book is about, actually, is about making more visible the wisdom of the working class, not just describing the experience, but letting the working classes speak their own experience with their own voices. So why is it that this wisdom is not only crushed by the condescension of history, but I think my experience in the Knowledge Network is that it's crushed by contemporary social science. Contemporary social science doesn't deal with the issue of the wisdom of experience. Why is that? Well, I have a few suggestions. Some social scientists don't even recognize that it exists, this lay knowledge. Maybe more of them dismiss it. And it is still the case that some dismiss it as primitive, kind of left over from some previous unscientific, less rational age. But I will still submit papers to journals and be told that the data is anecdotal. It's untrustworthy. It's anecdotal. Or that this lay knowledge is often researched, but it's researched as kind of curious beliefs that lead in some way to this risky, irrational behavior. So that's part of the reason. But I think another part of the reason why we neglect lay knowledge is that social science approaches used to access this knowledge are given low status. So it is still the case, even though the discourse within social science is now about equity between qualitative and quantitative methods, about complementarity between these methods. It's still the case that qualitative methods and the evidence that it produces is given lower status, I believe, than quantitative methods. But there is a growing recognition in the health field in particular, which is the field I know best, that this lay knowledge, this wisdom of experience, is important. It has important insights to give us. So I just very briefly want to suggest some of those insights where there is research evidence. And the first is there is now a large body of evidence, research evidence, accessing people's experience of health, ill health, healthcare, that has led to improvements in the quality of services. And the example I give here is that professionals, whether it's doctors or nurses or physios, are shifting away from this preoccupation with non-compliance. You know, why don't these patients do what we tell them to do? To an understanding that you have to understand how people use medication, how they interpret these instructions, and now the discourse and the practice is about shared decision-making. And that's based on a body of research around the meanings people attach to the taking of medicine and the meanings people attach to health practices. Qualitative research into lay knowledge, I think, is beginning to shift the understanding of risky behavior. The classic example is some work by an English sociologist called Hilary Graham, looking at why women living in poverty continue to smoke. And what she did was shift the discussion within public health away from a lack of knowledge or ill-informed people to understanding that smoking was a mechanism for coping in poverty. And that if you wanted to try and do something about smoking, then you had to address the context within which people smoked. Otherwise, if you did manage to stop them smoking, then they might actually do something else that was equally problematic, like, for example, eating the wrong foods and becoming obese. So this qualitative research on lay knowledge around risky behaviors is beginning to shift our understanding about the nature of those behaviors. And then finally, this lay knowledge challenges priorities for public health action, for health equity action. And the example I give here is of a piece of research that was done in Glasgow, in Scotland, when the local public health department had a major campaign around parental smoking with the intention of reducing respiratory problems in children. And the parents on 2 estates were arguing that, yeah, okay, it would be a good idea if we stop smoking, but we find it really difficult to stop smoking. But actually the problem is the damp in our homes. It's not our smoking. And the public health professionals refused to accept this. So this group went to a university group and got them to do a piece of research. Very good piece of epidemiology. And the results of the epidemiology showed that the parents were indeed correct. There was a dose-response relationship between the children's respiratory diseases and the damp in the homes. The more damp there was, the more respiratory problems the children had. And the relationship was stronger than it was between parental smoking and children's respiratory problems. Now, that might not have been the case, but the tendency to dismiss lay experiential knowledge is the problem, rather than to take it seriously and to test it. And of course, oppressed people can have very sophisticated theories about the causes of health inequalities. Now, social scientists very rarely ask people about what they think causes their ill health. And they very rarely ask people who are the most oppressed about this. But there is a very slowly accumulating body of research around this. And research in an inner city area in the north of England, a city called Salford, which interestingly is where Marx and Engels did their original research, which I was involved in. We found that these theories were quite sophisticated. They were multifactorial, just like scientists' theories. And there were three aspects to them. First, people identified stress as a major cause of ill health. It was the most common response to the question, was the reasons people in this area got ill and poorer people got sicker than other people was because they were stressed. And the two sources of stress that people referred to were poor material conditions and social comparisons. Seeing other people having better lives was a source of stress. So stress mediated for most of these people the experience of ill health. And secondly, they said that having strength of character, psychological resilience we might call it, protected people from the adverse effects of this stress. And this is a quote, quite a common statement. The first thing you do when you get up is you see the graffiti, the vandalism, and it doesn't help. But at the end of the day, it's how the individual deals with it. If you let it get you down, you're going to have health problems. So it could be taken out of a psychology textbook, actually. So first, the problem is stress. Second, the strength of character will protect you from this. But third, they were also aware of the wider structural determinants of their health disadvantage. This is another quote from all of the people we spoke to made the similar kind of quote. I mean, everybody has a bit of worry, but the outside worries that you haven't got any influence on changing, that has a bigger effect on you. I think like not having a job or no money. You can't sit down and think, well, I've got this problem, and how can I solve it? Because you haven't got the power to solve it. Now, these are fascinating, curious lay theories, but they serve a purpose which we need to understand. The first, and probably the most important thing from a social science perspective, is that these theories allow people to reconstruct their moral worth in a social context where simply to be poor is a challenge to people's moral worth. And Mildred Blackster, a sociologist that some of you may have heard of, who is now in her 80s, who's done a lot of work on lay knowledge, argues that to acknowledge inequality would be to admit an inferior moral status for oneself and one's peers, hence perhaps the emphasis on not giving in. This can be seen to be a claim to moral equality even in the face of clear economic inequality. We all do that. We all seek to reconstruct our moral worth when we're sick or when we're challenged. So these theories are doing that. But they also reassert individual control, the need for us to have a sense of control. So this focus on stress, which one can control through strength of character, serves a purpose for the individual. In the context, in an environment where actually the material constraints on their lives are out with their control. The third thing it does, these theories, is it allows people to reconcile those things. It allows them to reconcile their need to control, the emphasis on stress, with a recognition of the wider structural determinants on their lives. So I have a joke. Michael's heard this joke so many times. We're very familiar with one another's presentations, but I don't think any of the rest of you will. It's in most, certainly rich countries, what we do with poor people is teach them how to spend their money better rather than give them more money. Maybe not in Scandinavia, but certainly we have a tendency in England to do that. And so we run classes, for example, cooking classes, how to spend your money and make more nutritious food cheaper. And on this particular occasion, these women are being taught how to make cod's head soup. Cod used to be a cheap fish, actually. It isn't any longer, is it? So fish head soup. But the head of the fish is very nutritious, as you will undoubtedly know in Scandinavia. So here the lesson is fish head soup. And at the end of the lesson, the teacher says, has anybody got any questions? And there was just one question from a woman at the back of the class, and she said, just one. Whilst we're eating the head, who is eating the fish? So it's a sign of the political astuteness of people. So my final slide and my final point is on building research capacity. These WHO knowledge networks that I was involved with, the social exclusion one, which had members from around the world, they were extraordinary, personally transforming experiences, actually. But I think that they could be conceptualized as global communities of practice. This is a new language in management science. Rather than networks, we now talk about communities of practice. We were people in these networks connected from different disciplines. We were multidisciplinary, but we were also multicultural, and we were multisectoral. We had researchers, we had civil society activists, we had policymakers and practitioners. So it was multidisciplinary, multicultural, and multisectorial. What we shared was a common practice. That was an interest in co-producing knowledge for action for health equity. And I think that these communities of practice are potentially a model for social science to develop, for moving forward to produce a global evidence base, not just in relation to health equity, but in relation to any of the major social dilemmas that we face. But what kind of knowledge should we be producing? And I suppose that's my last and summary slide, is that I think we need to produce evidence for health equity that is globally relevant. A major problem, as I said, with the knowledge network's evidence base was that it was disproportionately from the wealthy countries of the world. And we need to shift that balance. We need to focus on problems and solutions that are globally relevant. But we need to combine these diverse knowledges. We need both numbers and voices, and we particularly need this wisdom of experience to be surfaced in the social science endeavour. And to do that, we need to produce the knowledge through more egalitarian, inclusive research relationships. So the academics need to come out of the academe and need to engage with more publics, as well as speaking to power. We need to speak to the oppressed more. Thanks very much.
Speakers join me here now. Thank you, Jenny, for being such a bridge builder, I would say, between different disciplines. And great. So we had some really fascinating discussions, and I'm glad that this was on the top, was on the agenda, or is on the agenda of the Social Science Forum. We now have to make sure also that it's on the agenda of medical and public health fora, where this is dearly needed. Let's turn this into a conversation with everybody. And any comments, thoughts, questions? Yes, please. Can you please identify yourself, and then for it there is a microphone here if you need, but we'll have to.
I'm not sure it's on.
Just shout.
Yeah. Okay, Johan Fritzell, Stockholm. As Michael said, I had the privilege of working in this Nordic network that produced some evidence, I think, for him concerning what we have done in the Nordic countries. But I want to now rather make a comment, or rather make a, if you could elaborate a little bit about the present situation, so much about the financial crisis, which we didn't really, or we started to know a little bit about it when you started off, but not that much. You could have an argument saying that now nobody should care about health inequalities because we have more serious problems, economics. Alternatively, and I know that some people think that this is now a window of opportunity for making rather profound social changes in the social order globally. And if you could elaborate a little bit about what's your opinion on that, or hope or fear for the consequences, midterm consequences perhaps, of the financial crisis. Another comment refers to what you started off by saying, what if you fail with closing the gap? If you could elaborate a little bit more on how you see it as a prediction. Jon Elster said this morning that social scientists, now you're not, but you are a social scientist, but not by training perhaps, but that we fail to make predictions. If we see it as should we see it as a prediction following the recommendation, or should we see it as a goal, as something that might mean that we see it as something to be up there in the public discourse, in the public discussions for politicians and supranational organizations to care about? Yeah.
Do you want me to go for it?
Well, you opposed two viewpoints at the beginning. No one should care about health inequalities because of the economic crisis on the one hand, as against this is an opportunity on the other. One of the things that we've tried to argue is that health equity is a social accountant. It's a way, I mentioned to you, Johan, I was talking with somebody from SIDA, from the Swedish International Development Agency, and I said, how do you evaluate whether your urban programs are effective? And he looked like he wasn't enjoying the dinner anymore. I said, do you think about health impact? Wouldn't that be one way of evaluating whether your urban programs are making a difference? See if people's health is improving. And I would argue, and that's what the Commission argued, that because the question is, why should the Minister of Transport or the Minister of Finance be concerned with health or health equity? In Norway recently, in that other city in Norway, in Oslo, the Minister of Foreign Affairs said, I am a health minister. In fact, every minister is a health minister. And I would say every sector is a health sector. So that one way we examine the effect of the economic crisis is the effect on people's lives, and the way that shows up is in health and health equity. I just said it in passing. The prediction globally from the ILO is that the number of people in vulnerable employment, defined as own account or family of own account workers, will rise by about 200 million in 2009. So it'll rise to about 800 million. Unemployment will probably rise by about 50 or 60 million globally. And worse than that, it won't show up as unemployment in low and middle income countries because they don't have unemployment registers. People don't file for benefits. They just take worse work because they've got to do something. And we know that that will impact people adversely because of the impact on health and the distribution of health. So I would argue, but I wouldn't I, that it's not that we should try and fix the economy for its own sake. We should try and fix the economy because of its effect on people's lives And one way we can see the effect on people's lives is health status and the distribution of health. So that when President Obama says that there's too much income inequality in the United States, I would say the reason that we know there's too much is because health is suffering, because otherwise you just get into some sort of religious discussion about whether income inequality sets the wealth producers free and trickle-down theory of economics versus some other theory. It's a sort of quasi-spiritual discussion. But I would say we know it's actually bad. We could support President Obama's view because of the impact on health equity. So I wouldn't put them in opposition, say cure the economy. I'd say take it as an opportunity to improve health equity. On the closing the gap, we thought a long time about that title. We very much wanted to convey the impression that this was not a prediction, but an aspiration. If we thought that it was totally non-feasible biologically to close the health gap globally, then I don't think we would have said it. But it was a statement, pretty much like I said to Manmohan Singh. I'd like to think that life expectancy for women in India could go from 63 to 86, as it is in Japan, that there's no good biological reason why that should not be the case. The fact that it's because of social and economic conditions and environment and culture, the caste structure and so on, is a statement, well, okay, we know what to address. So it's not a prediction. And it's a bit like we've had targets for health inequalities in the UK. So far, we haven't met them. But I don't think it was a mistake to set them, because a lot of people have got fussed with, well, what should we do? We've got these targets. We better work hard to see what we can do. And there has been progress with the health of the worst off. One of the messages from the news group was we shouldn't only look at the gap, we should look at the health of the worst off as another measure. And in Britain, the health of the worst off has improved, even though the gap hasn't closed. And I think that, at least in part, was because we set targets.
Thank you, Michael. Any other comments? Or can see. Yes, please, over there.
My name is Sanjay Hazarika. I'm chair of the Center for Northeast Studies at Jamia Millia, which is one of the universities in Delhi, and I also run the Center for Northeast Studies and Policy Research in the northeast of India. And I'd like to very strongly support what you said in terms of lay knowledge and the need to involve the public in the work that you have been talking about, because I think it's absolutely critical to understanding what people really want. Because health is an entitlement of the poor. It's not an act of charity that the government gives or research institutions dole out. I think that as a right, it is very important to see it from a rights perspective. That's one thing. The second thing is that I think Dr. Yesudian spoke of the National Rural Health Mission, which is actually quite an amazing, because we partner it in one part of India, one state, where the maternal mortality level is very high, 458 in the state of Assam. And we run 10 districts through an innovative partnership with them, because it's a river, it's a state, the state of Assam, where floods are common, very much like Bangladesh, and we run a network of ships that take health services to people on islands. And that is quite unique, and it's come as a partnership with the government. And I think innovation is absolutely critical, because we're reaching about 200,000 people every year, and next year we'll be reaching 1 million. That's 1/3 of the most vulnerable people in that state. So it's important to partner government, and also it's important to see this, as you pointed out, as a rights issue, not just as an act of doling out.
Well, I think I agree entirely that there's a rights issue. I think it's quite important to distinguish between the people's right to health, people's right to be involved in decision making, which in the UK we're not very good at doing that. We say all the right things, but we don't actually. The practice is appalling of public involvement in decision making. But I think in terms of the focus of this forum, there is also a really important neglected scientific area around the study of lay knowledge and the salience of that for our understanding of problems, whether that be individual behaviour, as of this morning's plenary, or collective social movements, etc. So I think that those are separate issues. And in research, we also need to be accountable and involve people in the research process, so that they're kind of importantly separate but related issues.
I think India is maybe one country in the midst of all this economic crisis is able to invest more in the health sector. This National Rural Health Mission is started in 2005, and with today the annual outlay of $260 million, especially focusing on those states that are where the health indicators are much lower than the national average. And but the only concern there is there's a lot of money pumped into these areas, but looking at what is the capacity of these states to use this money meaningfully. So some of those issues, and also the evidence based, like they have health activists, an army of young women in the villages were trained to identify diseases and refer them to government facilities. And so how these things are impacting, even these 3 years, there is hardly any evaluation. So I would say even 2% of that 250 million is kept for some research to see how it is impacting on communities, and also to give further direction, because this money is government is using very flexibly, allowing states to innovate. So first time we are seeing the government health sector is innovating. Earlier, a lot of non-governmental organizations doing a lot of innovations. Government innovation has much wider impact. So sometimes it may have negative impact. So it's very carefully, very evidence-based innovation is very important. So that's what I want to say.
Thank you, Ashok. You mentioned the development of public health, schools of public health in India, which I think is indeed very important. My understanding is that they're not going into the direction that I believe is necessary, where there is for 21st public health schools should involve the social sciences and should have this, should be rooted in community practice. And am I too pessimistic, or what? What's your reading?
I think I may be much more pessimistic than you, because the government has planned to establish 5 or 7 schools of public health, because this is the first time a large country, they have estimated several thousands of public health managers needed all over the country, and first time they're established. But these schools have not really been, 3 of them are already being established, but they are much more like training government officers rather than academic institutions where there is some foundation for research and also good academic training, good public health practitioners. So they are not also based, they do not have, like we have a community laboratory. So such type of community laboratories have to be established. So this foundation still is very shaky. There's a lot of professors coming from Harvard or the Johns Hopkins coming there. That input has to be crystallized for the local need of the country. So that's not really happening. The local faculty have not taken advantage of these things. So but the social science part is still weak in these schools of public health. So that's very unfortunate.
It's an opportunity not to be missed now. Please, you have the comments and then you.
Peter Elias, the University of Warwick and the UK Economic and Social Research Council. Questions for all three of our speakers, so a bit of a mixed bag, I'm afraid. But can I start by asking Michael a question? One of the problems that I think we have looking across the globe at the relationship between social structure, economic structures and health inequalities in particular, is about the availability and the comparability and even the access to different types of data. There are some sources, and in fact in Professor Yasudian's presentation we saw one of those sources, the Demographic Health Survey, where a lot of work is being done to create data which are readily available, which are comparable. A lot of work's gone into them, and they're accessible very shortly after the surveys have been conducted. All credit to USAID and the agency that produces those data, but it's a small drop in an ocean of requirements that we need. And my view is that most of the data that we would like to get hold of is in fact part of the administrative structures of countries, and it comes from the operation of their health services, their social security systems, their taxation systems, and so on. We all know there are enormous weaknesses with these data in terms of their coverage, in terms of their definition, and so on. But should we not be making more effort to try to integrate and make better use of administrative data from different countries? A question for Jenny. Well, first an observation. I like your presentation very much, Jenny. I think it's really important. Michael started off by talking about the causes of causes, but I think you were getting into almost the causes of the causes of causes, looking at the way in which we see processes illuminated by the personal accounts from individuals and drawing on that experience. I was very impressed with a particular website I came across recently in the UK, which is called DIPEX. You might know this, Anne McPherson's work. And McFarlane's work. DIPEX arose because there was felt to be a need for patients who'd experienced different kinds of treatments to engage in discussions with each other and to share their experiences. And as this website has grown, and these personal accounts, which are mediated by researchers, and that's quite important, I think, it's created what I consider to be a very valuable research resource, which can go alongside clinical trials and alongside epidemiological research. And it's that marriage between the quantitative and the qualitative. I'm not so keen on using these words to make these distinctions, because I think we have to have all different types of evidence in our search for knowledge. But the point I'm making here is that this has been facilitated by the web. And I'd like you to reflect upon your views on how you think the internet and technology is going to change, is likely to change the way in which we can gather and process information of a more qualitative dimension. And finally, a question for Professor Yasudian. You reflected back 30 years to talk about the previous link between the ICSSR and the ICMR, and the fact that that gave rise to particular actions, and that this was now about to happen again. I'm very interested in this because in the United Kingdom, one of my tasks is to work more closely with the Economic and Social Research Council and our Medical Research Council to promote research at the interface between the biomedical side and the socioeconomic side. Could you say a little bit more about how this link between ICSSR and ICMR will work? Who will have the money? And how will these bodies work to commission research which lies at this important boundary between the biomedical and the social sciences? Thank you.
Wow, quite an agenda. Michael,
Yeah. Well, your point's an absolutely crucial one. We said in our report, the report of the WHO Commission, our third area for action was to improve monitoring capacity evaluation. we were struck, and we're not the first to draw attention to these issues, but we're struck when you look at low-income countries, the high proportion of babies that are not registered at birth. So the idea that we're going to get better data on health equity when we're not even getting data on births and deaths is a significant challenge. And we think it's urgent and a high priority. It's not just taking social action at the policy level, but it's urgent to count, to absolutely improve these systems so we know what's going on. I mean, I went to a lecture by a distinguished economist to 2 separate lectures asking the question, have poverty levels in India gone up or gone down? And he was raking over all the various sources of evidence, survey evidence in India, to ask that question. He spent 2 hours, 2 lectures. And I thought, this is quite remarkable. There are 193 countries that we're concerned with. And one of the world's most distinguished economists spending hours just reporting on years of research to answer that one question of poverty levels gone up or gone down with the economic growth that had happened in India. So it's a way of saying that key to further developments in this area is improving the quality of data globally. The limitations of the demographic and health surveys, for example, is that they only give data on infant and child health. We know absolutely nothing from those, or next to nothing, about adult health and adult health inequalities. And so often when I'm citing data from low and middle income countries, I'm citing demographic and health survey data on child health, faute de mieux. We haven't got anything else. That's very important. So one of our key recommendations is for WHO to improve the quality of measuring systems. We've also proposed a measuring framework, and we published a version of that in Britain last Thursday, of not just monitoring health inequities, but monitoring the social determinants, the drivers of these health inequities. And we tried to show for a country with relatively good data how it could be done. But we would urge the international system and individual countries to see how they could try and apply this. Very much picking up your point.
Yes. Jenny?
Thank you. Thanks for the question. DIPEX, Direct Patient Experience, it's called. I think it's quite important to recognise that it deals with medical conditions, people's experience of healthcare for medical conditions, particular kinds of cancers, and it is an amazing resource. But behind every one of those visual accounts is a very sophisticated piece of qualitative research, which is quite expensive. They usually have samples of 20 or 30 people interviewed in depth and videoed. So the DIPEX is the front end of a process of research. So it's quite important to kind of know that, I think. The use of the internet, I think, in all research will be important. I mean, there is research, qualitative research going on at the moment, gathering narratives about different experiences from the internet. I personally, maybe I'm a dinosaur, is maybe the point I am in my life course, but I don't think it can ever replace fieldwork. And I think that the core reason for that is that whether we call it qualitative research or interpretive research or research which is trying to understand the meanings people attach to their experiences, we need the context. That's the whole point of this kind of research, that it's context rich. And although you can get a bit of an angle on context using the internet, I mean, I've done a bit of research getting young people's accounts of driving on the internet. It's thin on the context. The research that I described, where we collected accounts of theories, lay theories, that was an ethnography in an inner city area where we were in the field for 2 years. So I took a little bit out, but actually the research was quite complex in its design. So yeah, I think the internet will shape the way we all do research, actually, but I don't think it will replace some of the traditional tools in the toolkit.
the two issues. One is the availability of data in country like India. Actually, the data that is available with the government is basically the data that is generated by the government facilities. And if you look at the people, only less than 30% are going to the government facilities. So actually, the government has no control over the private sector where people are going. So the country doesn't have a surveillance system, integrated surveillance system. So it's very difficult, whatever now government has made all the data available with them on their website. So it is available, but that data is just tip of the iceberg. The whole private sector, there is no regulation from the government side to report the notifiable diseases. So that's one thing. And coming to the main question, ICSSR, ICMR, that was 30 years ago, it was the circumstance and the leadership. The circumstance was a 1978 Alma-Ata Declaration where WHO was proposing that primary healthcare approach. That has created so much of interest in the government. So the Joint Commission was set up by the Prime Minister to come out, because till 1983, India did not have a formal health policy document. So this was the first attempt to create a policy document, national health policy document. So, and the leadership in the chairman of the ICMR, Professor Ramalinga Swamy, and also ICSSR chairperson, I forgot his name, these both came together to produce these documents. So the top level scientists in ICMR and top level scientists in ICSSR, they have worked 3 years to bring out this document, Health for All, with a lot of evidence, and but later the policy never got implemented. That's a different story. But over a period of time, the Joint Commission used to have a common fund where they were sponsoring research, social science research in the field of health. But ICMR grew stronger and stronger. ICSSR grew weaker and weaker over a period of time. So this, they part away. Actually, I am in the social science committee of ICMR, where ICMR has a lot of funds available for social scientists to do research. They have PhD fellowships for social scientists, kept separately for social scientists. So today ICMR actually is focusing on social science research to some extent, not to the extent of medical research, but it is happening independently. What I feel is a joint hand with the ICSSR is very, very important.
Thank you. We had questions there and then over there.
Yeah, my name is Ole Fridtjof Nordheim. I'm professor of medical ethics at the University of Bergen here, and thank you for very interesting talks. There are two issues that strikes me when I follow this debate. The first is that even in an egalitarian society as Norway, we have so huge differences, for instance, in life expectancy. One study showing a 10 life-year difference in life expectancy between two parts of Oslo. And the other thing is, the other observation is that there is a relative absence of public debate about this, about a public concern about this. So I guess I have a question both to Jenny and Michael. Why is there so little public debate among lay people? Is there a lack of knowledge or a lack of concern about this, or is the issue too complex? And to Michael, why is there, or is there little public debate about these issues? Thank you.
I'm in danger of sounding like an old fogey, I think. I'm certainly talking about Britain. I'm very distressed about how little public debate we have about anything important. We have, I mean, it's just remarkable. I wouldn't recommend it, but if you looked on the web for what the weekend's newspapers were full of, they're all full of an MP that charged for tampons, for expenses, and a bath plug, and a very important issue. I really think it's absolutely fundamental to our democracy that we should know whether MPs were charging for bath plugs and getting reimbursed. Very important issue. But we've got some really, really big problems, really fundamental to our society, and we're not debating them. And my guess is if you walk out in the street in Britain, I'm sure the Norwegian population is better informed than the British population. But if you walked out in the street in Britain and and ask them the question. If you put to them exactly the data with which you began, there's a 10-year difference in life expectancy in one part of Oslo compared with another. Actually, I was told it was 11 years, but it's never mind. Why? They'd say, well, the people in one part probably don't get to see their doctor. That would be the understanding. So we really need, I mean, if we're going to take up Jenny's point about people understanding about stress is important and the nature of society is important, we really have to have much more public debate about these issues. Now, I know the data from Sweden. If you look at life expectancy for women between 1990 and 2005, the inequalities have been increasing nationally. It's getting better for everybody, but the gap has been getting bigger. Now, this ought to be a fundamental debate. This really ought to be about the nature of society, and that it ought to be part of what people take on board when they're thinking about who they vote for in the election. Who's actually providing a vision of how to get a fairer distribution of life chances which show up in health. So the fact that we all look, well, at least I do, with great respect at the Nordic countries, but see the major challenges that even the Nordic countries have, because now those OECD data that I showed you for England and the US, if I'd shown them for Sweden, growing income inequalities in Sweden. So that it's not as if the Nordic countries have solved these issues and they've gone away. They're still there, and we're not debating them. So I think a key issue is getting this much more into the public domain.
I don't often disagree with Michael, but when we went out to ask people, they didn't say it was the doctor. I think it's a very complicated, as you would expect. I think this is a very complicated set of issues. But if I could just say, when we spoke to the people living in these 4 areas, there were 2 very, very rich areas and 2 of our poorest areas. And we were there for a couple of years, so we got to know these people. And when what we did was show them the life expectancy for the 2 different areas. This is yours and this is theirs. Why do you think this is a problem? And we showed them childhood accidents, and we showed them a couple of standardized mortality ratios. And the first thing they all did was disbelieve the statistics. And particularly in the poor areas, they denied the inequalities. That was their first position. And I think the reason for that is the moral dimensions of illness and inequality. It's Mildred Blackster's quote: to own the problem is to see your moral status undermined. So if you can't look after your children, you know your children are dying more earlier than those children. They don't live as long. It is my fault. So asking people these questions, I think, they're moral questions, and so you're not going to get easy responses. But over the length of the conversations, it was clear that there was absolutely no lack of understanding about the social determinants of health. The quote I showed you about the little worries and the big worries. The language might not be our language, but there was no lack of understanding. And that was the rich who were very embarrassed by this. They didn't talk for very long. And the poor who talked for a long time about it. So it seems to me that in England, the people understand we're a very hierarchical, socially divided society, and people know about social status, they know about hierarchies, and they do know it impacts on their health. Then there's the issue of why isn't there a public debate? And I think that's partly about this moral stuff. You know, we don't talk about inequalities very much in general, but I think the last 20 years in England's been really important because we've lost what sociologists refer to as the public sphere. You know, Amartya Sen was saying yesterday that enlightenment is about having conversations, having dialogue. Well, we lost, under Margaret Thatcher, a lot of our spaces for dialogue. The labour movement was destroyed. The labour movement was where a lot of working class people used to debate these issues, yeah? our communities were really quite badly damaged. So there is a literature in England about the loss of the public sphere, where this dialogue, this enlightenment process can happen, and we don't have it. So that's a problem. It's beginning again, but it's a problem. The public health community is a major problem. I mean, they talk about obesity and smoking, but they don't generally talk about the wider social determinants. And they control the agenda to a large extent. Now, again, it's beginning to change with the Commission and with Michael's influence, but they're a big problem, our public health professions, I think. And then we've got the media, who, of course, you know, with this latest swine flu, they're not talking about the possible link with the way we produce our bacon, for example, as a social determinant. It may or may not be the case, but you know, the causes of these things don't get debated in our media. Absolutely, absolutely not. But we've got lots of headlines about obesity, fat people. So I do think it's complicated, but I don't think it's ignorance on the part of I think that's not the problem. We do have a level of ignorance amongst our public health community, but the public are not ignorant, but they are inactive. They're less active than they should be.
I fully agree with Jenny. And last question or comment, and then we'll have to end the session.
Hello, I'm Kristin Ormhaug from the Norwegian University of Life Sciences. And my question is perhaps primarily to Michael. I'm trying to write about health effects of conflict. And in doing so, I'm trying to dip into knowledge from conflict research and also dip my toes into the public health field. And you don't have to try and do that very long before you realize that there are wide differences between communities. When you go to conferences, you see there's the public health community and then there's the conflict research community. They don't really speak together. And they use the same words and mean completely different things. And in writing your report, I suppose that you were working with a lot of different scientists coming from different backgrounds. I would like to hear your reflections on what you did to, or what kind of challenges you met and what you did to overcome, not the least, those challenges, because this is something, I think we all agree that it's important to integrate knowledge from different fields, but it has real practical difficulties coming with it. Could you please say something about that?
That would be a good end for the session.
I'm happy to comment. Firstly, let me say I agree with Jenny too, that when I said you asked the public, in fact, what I'm reflecting is you ask the policymakers in the public health community, and what you get is it's healthcare. We were also involved in little case studies of asking people about health and health, what affects them. And what we got was, they're telling me to exercise, but you should see where I live. And they're telling me that children are getting fat, but I live in a high-rise block, and downstairs is graffiti and broken glass and crime, and I'm not going to let my children go downstairs and run around and play, and so on and so forth. So we got a lot of that. So I agree with Jenny's correct. The issue of speaking, I mean, firstly, specifically on conflict, and then the issue of speaking to different audiences. The Eastern Mediterranean region of WHO did a report for the Commission on conflict and health inequities, because there's some large number of the countries in the region are involved in conflict. And conflict, like I was saying about environmental influences, and as with the economy, of course, impacts the poor and disadvantaged more. There was a report from the island public, from the Republic of Ireland, and Northern Ireland. They've got together in a public health institute, and they produced a report. One of the things they pointed to was that the violence, the troubles in Northern Ireland impacted the poor. It wasn't the wealthy and the middle class who were great. It was an inconvenience, but the people who are actually getting beaten up or shot or killed and whose lives were made a misery were the poor and the disadvantaged. So the issue of conflict is a big issue for health equity. We discussed this a bit on the Commission, and we were a bit floored by what do we say? I mean, we think it's a bad thing, but actually dealing with the causes of conflict is really pretty fundamental. And we weren't quite sure that we were equipped to say a lot about the causes of conflict while recognizing what a huge issue it was. But your more general point of talking to different audiences, this was a major challenge for us, of course. I'd like to think that I started off by saying I'm a physician and come from a medical background, but learnt to talk to different audiences. And for example, one of the big issues for me personally was right at the beginning of the Commission, when we took the decision we were going to engage with civil society. They very much spoke a different language. They didn't speak my academic speak at all, and I didn't speak their speak. So for me, a big learning experience was learning how to talk that language, learning how to translate, as it were, but also the point that they made to us was we have knowledge too. Our knowledge is a different form of knowledge from your knowledge, but you've got to listen to our knowledge as well. And we did. It was really very important. I think we were helped also by the variety of commissioners that we had. Some experienced politically, some social scientists, some medical people who are used to speaking in different spheres. And I think among the commissioners, they had to learn just to communicate with each other when you've got people who are really technical economists and somebody coming out of the People's Health Movement and somebody who was Minister for Women and Social Development in Senegal. They're coming from very different backgrounds, and actually or the former Minister of Health in Iran, who's a professor of pediatrics. And what was quite remarkable was actually watching these people learn to talk to each other. So I'm not sure that's a very detailed answer to your question, but for us, very much learning to talk different languages was a key part of it, so that you could actually say, we recognize the knowledge that you have, and ideally you're able to recognize the knowledge that that group has, and we can put those things together.
Thank you very much, Michael Ashok Jenny, for a really outstanding panel. Thank you to everybody who intervened. I think that it's safe and fair to say that there is enough evidence for the, I would say, sometimes overriding role of social determinants in health and ill health, more than enough knowledge to act, a need for pluralism of methods to move forward, a great need for research from the side of the social sciences, and also I believe now what we need is joining forces to turn this into policies and action. And I hope that this debate will have contributed to that. So, thank you.